It's my honor to introduce our keynote speaker this morning, Dr. Matt Miller. Dr. Miller is the director of the Suicide Prevention Program at the Office of Mental Health and Suicide Prevention in the U.S. Department of Veterans Affairs. His team is dedicated to addressing suicide prevention, intervention, and postvention for 19 million veterans nationwide in conjunction with the more than 140 VA health systems. Dr. Miller previously served as the director of the Veterans and Military Crisis Line. Under his leadership, that became the world's largest and most effective suicide crisis call center. He served as an officer and clinical psychologist with the U.S. Air Force. He was awarded the Air Force Commendation Medal for service rendered as part of the war on terrorism. And we could not think of anyone better to deliver today's keynote. So Dr. Miller, thank you so much for joining us. I'm going to turn it over to you.
Thanks, David. I appreciate it. And as a veteran, as you mentioned, I very much appreciate your statement regarding veterans and resiliency, and that perspective entered in. So thank you. I love New York, and that's not just a bumper sticker. As was mentioned, our Veterans Crisis Line call center is located in Canandaigua, New York, at the Canandaigua VA Medical Center. And that is the origin of the Veterans Crisis Line, and in many ways, suicide prevention within the VA. So there is a rich history with New York, with the Finger Lakes region, and with VA suicide prevention and the Veterans Crisis Line. The only thing I can say that maybe I'm not as of a favorable of opinion with New York is perhaps the tollways. I do recall that the first time that I flew into Rochester, then made that drive in a rental car to Canandaigua, one of those awkward, embarrassing situations where there was a toll. I didn't know there was a toll. I was on government travel. I didn't have any cash. And I pulled up to the off-ramp for the toll. And the attendant, this was pre-COVID, said, that'll be a quarter. And I didn't have a quarter. So I'm like looking through, this isn't my car, it's a rental car. There's no quarters to be found anywhere. I looked at her and I said, I don't have a quarter. And she looked at me with probably a look that she's had to repeat on several occasions throughout her day there in that particular work, and said, you don't have a quarter. I do not have a quarter. I'm so sorry. I mean, what do? I mean, I've got this card. I can give you a card. So without even looking around, just looking straight at me, she reaches into her pocket, pulls out a coin, drops it into the register, and she says, you can go this time. So every time I travel to New York, I do make sure, just in case, I have a quarter and I have some cash on hand for those tollways. But completely worth it. Again, love New York, and love our base of operations out of the Canandaigua VA. You know, I want to share some things with you all this morning as you're gathered to talk about suicide prevention. And I'm really looking forward then to giving way on the floor and the agenda to some incredibly strong allies of veteran suicide prevention and veteran mental health care. So looking forward to hearing Heather, Kelly, Dwayne, others talking about suicide prevention and lending their expertise. What I wanted to share with you, I'll start with hope. And many of you know that well, it's been about a month now the VA released its annual report on suicide prevention. And for those of you who have had a chance to review the annual report, you'll see that it starts with a section called Anchors of Hope. And really, we put that section in 2 years ago and carried it over this year, because hope and having factually based and grounded hope is really important in terms of moving the mission forward and providing the fuel to do so. We know this in our individual lives. We have hope for today. We have hope for tomorrow. We have hope for certain things in our lives. And that helps to provide fuel for why we do what we do individually, professionally, on a day in, day out basis. And having a grounding in hope is particularly important within suicide prevention, where the definition of success is really ambiguous and really, I think, difficult to specify. When you're talking about the loss of a life, how much more than one matters. One counts significantly. So we can talk about reductions or changes in rates and counts, and that's important. It's a necessary part of the work. But in terms of success, how can you talk about success when really it's 0 or 1 or greater, and 0 is the best definition of success? So as we continue to work towards that definition of success, maintaining hope is critically important. Now, that hope that we maintain does not become something that we say mission accomplished with regard to. Again, I go back to the 0 or the 1. But we did see some unprecedented signs of hope within this year's annual report based upon 2019 data from the CDC. First and foremost, let's talk human lives. We saw 399 fewer veterans who died by suicide in 2019 compared to 2018. That's the first time that we've been able to stand in front of you and talk about a decrease in lives lost versus an increase in lives lost. When you look at the averages from 2001 to 2019, you see that on average about 48 to 50 lives additional were lost to suicide within the veteran population each year. So to go from a yearly increment of 48 to 50 increase per year to then 1 year switching back to 399 lives that were saved, that is significantly meaningful. And again, unprecedented. Another aspect that these numbers translate into that was unprecedented was there was a 7.2% decrease in veteran suicide rate. Rates generally the best indicator helping you to scale the numbers. Some people say, well, but there was a decrease in the US population suicide rate as well. So maybe it was just a byproduct or a reflection of that. My response to that would be that the general adult population decrease was about 1.8%, but the veteran decrease was 7.2%. Usually in the past, we've been on the other side of that in terms of having a more significant increase in veteran suicide rate than the US population. To reverse that to a 7.2% versus 1.8% is significant. Now, within the context of that, we also know, and David mentioned this, that veterans are at a higher risk for suicide. The difference still in the 2019 data between the US adult population and the veteran population was about 52%. That's better than when that difference, that gap was at its most significant, which was 2017, and that was about 62, 63%. But there's a lot of work that remains to be done. And that's where we transition from the importance of having hope and grounding it in fact-based information to something we learn in the military, which is hope is not a strategy, and the importance of strategy. So it's my hope that within this time and within this assembly, it's an opportunity for you to, yes, find grounding for and reasonable reason for hope, but also for you to talk, think, and refine strategy with regard to suicide prevention. Now, when I think about strategy, I think about the 4 Ps. So the 4 Ps of strategy that come to my mind are first, position, then priorities, then payments, and then performance. I'd like to real quickly walk through those 4 aspects of strategy so that we can then set and finalize the table for the rest of our time here together and the incredible speakers and panelists that you're going to have a great opportunity to interact with and hear from. So from a position perspective, this is where our mission, our vision, and our values come into play. So what in this domain of strategy unifies us? I propose to you that we have a unified vision and values, and those values are threefold. Number 1, we believe that suicide is preventable. It is not inevitable. We believe that this is true in the clinical domain and sense, but also in the community setting. To explain, or support may be better stated. At the clinical level, some cases in point, we know, for example, that implementation of safety planning in the emergency department, such as what we're doing across the VA and VA emergency departments and urgent cares. We know that safety planning in the emergency department has the potential to reduce suicide behaviors in a very high risk group by 45% across a 6-month time period following the emergency room discharge. 45% reduction in suicide behaviors. That's massively significant. Another case in point in terms of suicide is preventable and within the clinical subdomain. We know from taking a look at veteran data in the annual report that from 2005 to 2019, we've seen a significant decrease in veteran suicide rates for those veterans who are in VHA care and diagnosed with depression or an anxiety disorder. Those are both elevated risk groups. And to see the suicide rates decrease across time in those groups with treatment is a good example of this. I think the third example is pretty similar in that we see that across 2001 to 2019, veterans in VHA care have seen a lower and slower rate of increase in terms of suicide rates compared to non-VHA and very comparable to the US adult population. But what about on the community level? So we know the clinical, but what about the community level? One of the most really fascinating study that came out 2019, it was by Steele-Smith and a group of authors. I think it was in JAMA. It talked about community factors that were found to be highly correlated with suicide rates within the community. So the factors that were studied had to do with deprivation levels, fragmentation levels, and social capital levels. Now, think about some of the variables here that go into each of these. So fragmentation, social fragmentation had to do with how much transience was characterized within the community, people moving in, people moving out, rental sorts of housing arrangements. In terms of deprivation levels, they were looking at education opportunities and advancement, occupational opportunities and advancement, and financial status, well-being, and health within the community. From a social capital perspective, they took a look at resources within the community that were available, social organizations, recreational opportunities, access to health care, things along those lines. What the study found is that suicide rates were higher in communities where social capital was decreased, social fragmentation was increased, and deprivation levels were increased. And then the converse was true. Suicide rates were lower within the communities that had high social capital, low fragmentation, and low deprivation levels. All of that said to say, there are things that we can do here on the community level that meaningfully impact suicide prevention. Value number 2, suicide prevention will require a public health approach. What does this mean? What that means is that you take policy, you take clinical, and you take community, and you say, I need all three. All three have to work together. And if you pull any one or separate any one of those out, you do not have a true public health approach then to suicide prevention. Yes, you need clinical interventions and the best possible clinical care, but suicide isn't always about mental health. Suicide isn't always about clinical care. You need those community-based interventions, policies, and programs that address those non-clinical domains that I think Steele-Smith so nicely highlighted and illustrated. Value number 3 is that suicide prevention will require all of us. David mentioned this in his intro, and it's so true. The more that we are able to move towards collective engagement with no one sitting on the sidelines and saying, well, let's see what the VA does this year about this. The more we're working together, the more within that collective engagement paradigm, we're going to continue to move forward suicide prevention. From a priorities perspective, there are 3 that stand out with the governor's challenge and 3 that I think are important to focus on, where we take those values and we funnel them in terms of here's what we're going to focus our actions on. Number 1, identifying service members, veterans, and families, and screening for risk for suicide. Number 2, promoting connectedness within the community, across the community, and importantly, within improving care transitions and care coordination. Number 3, lethal means safety awareness and engagement in the clinical setting, particularly with safety planning. Look, it's fact. 70% of veteran suicides are secondary to firearms. The more that we can engage principles of lethal means safety, the more that we can address the how 70% of the time explaining veteran suicide. From a payments perspective, I want you to keep your eyes and ears open for some exciting opportunities, one of which is in close work with Heather and colleagues in Congress, the Staff Sergeant Parker Gordon Fox Suicide Prevention Grant. We're looking forward to opportunities to infuse communities with funding, support, and resources for veteran suicide prevention, and partnering with the VA to do so through these grants. And then finally, from a performance perspective, we highlight the importance of measuring what we're doing and reporting what we're doing, both in terms of process and in terms of outcomes. Outcomes, we take a look at proximal, what's near, what's close, and we take a look at longer term sorts of outcomes. Really important, particularly in the governor's challenge, that we incorporate all of those levels in terms of performance, because you need to be able to show that you're making progress towards the steps, towards the ultimate that you're wanting, which is decrease suicide rates overall. So my hope for your time today is, again, that this serves as a time where you learn facts and information that provides you with hope for what we are doing together and inspiration for what we're doing here. Second, I hope that you're able to convert that hope into some ideas for the 4 P's of strategy. We talked about our shared vision and values through the 3 values. We talked about our 3 priorities, particularly through the governor's challenge. Talked about some funding opportunities. We talked about some measurement and performance aspects. So looking forward to you being able to hear from some great panelists and subject matter experts here, and hope that this is a really rewarding time in the mission and the effort for you. Back to you, David.
Okay, well, thank you so much, Dr. Miller. That was excellent, and you've really set the stage for this morning and tomorrow morning. If you can pop back, I was going to ask you one question, if that's possible. Okay, the 2019 data that you spoke about was very encouraging indeed, but it feels like a long time ago, given all that we've been through, in 2020 and 2021, and understanding the realities. There's always a lag in data collection. Is there any way that we can get something closer to real-time data on veteran suicide?
Mm-hmm. A couple comments about that, David. First, the data that we have and use from our annual report is that which we get from the CDC and then is matched to veteran and DoD databases. It is highly reliable and valid and therefore important. But as you mentioned, there is a time lag there that's part of and assists with the validity and the reliability that the data does hold. In terms of what we're seeing in 2020 and 2021, all the signals that I have available to me, signals such as what's going on in the ER, what's going on in primary care and mental health, what's going on with issue briefs coming from VA facilities, indicates that there is not an increase in suicide attempts or deaths from onset of COVID to the present. That's good news. However, I acknowledge that the data is not complete. We won't have those full signals until the CDC data comes out. There was a, finally, I'll note that there was a publication in JAMA Psychiatry, I think it was last month, about 6 weeks ago now, that took a look at the veteran population specifically and suicide behaviors, particularly ideation, and took a look at is it increasing? What's happening here? The data overall found that there was not an increase in veteran suicide behaviors post-COVID, but it did note that there was one subgroup that there was an increase. The subgroup that reported an increase in suicidal ideation were characterized as veterans who were higher risk going into the pandemic. So veterans with a mental health diagnosis or substance use disorder, veterans who were characterized with a living situation that was fragmented or separated. Veterans who are at high risk going in did experience a notable increase. So for that reason, we've been working hard in the VA on unique outreach for those veterans who are high risk flagged for suicide and diagnosed with COVID, and have been engaging in intensified outreach to that population in particular. I hope that helped, David.
Yeah, thank you very much for all that helpful information. And we'll go deeper tomorrow in one of our sessions on high-risk veterans.